We were doing variceal bleeds. So basically, uh, variceal bleed is a type of GI bleed. Okay, so there are so many types of GI bleeds: upper GI, lower GI. We did it like above the ligament of Treats, it's upper GI territory. Below the ligament of Treats, it's the lower GI territory. Now, it's important for us to understand that in the upper GI, esophageal gastric varices is a major cause that comes in the EDIC exams. Then is the gastric ulcer bleed, which can also come in the exam, but usually because it's more of a surgical correction, uh, that is why surgical or interventional. So that is why it is not considered much as an EDIC part, but the variceal bleed is a very, very important EDIC topic. Same way, Mallory Weiss tear is very important, very, very important. Then comes the lower GI bleed, in which diverticulosis, diverticulitis, angiodysplasia, these are important. As far as IBD, ulcerative colitis, Crohn's disease, they are not as important topics for intensive care. Okay. So typically the variceal bleeds, they happen in the setting of cirrhosis with portal hypertension. So whenever there is portal hypertension, there is a uh, venous pooling of the esophageal blood vessels and all the veins that drain into the mesenteric venous system, because that is the system which drains into portal veins. And portal vein, because of its hypertension, it doesn't accommodate any further blood flow coming from the veins of the alimentary system. So what happens is they remain inflated and there are higher chances of bleeding due to pressure. Why it is important for us as intensivists? Because it has high mortality, and given urgent response, the chances of survival of these patients are very good. So we will have a situation: a 54-year-old male with known alcoholic cirrhosis presents with large volume hematemesis. Blood pressure is low, 82 by 48. Heart rate is 112, GCS is 14, abdomen is distended because of ascites, there is caput medusae. HB is only 7.6 grams because he's come with large volume hematemesis. INR is 1.9 because he has cirrhosis. Platelets is 54,000. Can anyone tell me why platelets are low in patients of cirrhosis with portal hypertension? Anyone?
Platelet sequestration.
So it is because of splenic sequestration. Also, the hormones, that is the thrombopoietin, its metabolism is affected and it leads to thrombocytopenia. Also, because of vitamin B12 deficiency that happens in patients of cirrhosis, there is. So there are multiple reasons. One of them is splenic sequestration. All right. So you are the registrar on call. So what is the initial step in managing? As in EDIC exam, you will be provided with a case-based scenario. So you will be asked what is the next best step. So the next best step of a patient coming with variceal bleed is basically resuscitation. Resuscitation with crystalloids. So if the patient's ABC that you have checked is okay, that means the risk of aspiration you've ruled out, the patient is not in encephalopathy, the patient is conscious if the GCS is more than 8, then you can continue with resuscitation right away. Or if the patient's GCS is less than 8, these patients require immediate intubation so that they don't aspirate. Then you provide them with good amount of oxygen, and to maintain the circulation, prefer a peripheral line. Prefer two large bore peripheral cannulas instead of going for an IV, central venous access, which carries its own complications. And in a setting of patient with coagulopathy, these patients may have higher incidence of bleeding. And sometimes, if you get an inadvertent arterial puncture, then the chances of dying because of an arterial bleed is very high. So ultrasound guided venous access is the complete answer that you should offer. But if there is a chance that there is an answer that two large bore IV cannula, that will be the preferred answer in case of a patient. Although if the situation is given that the patient is also having generalized anasarca, then you should opt for ultrasound guided venous access. They will not give you a central or peripheral, they'll just mention ultrasound guided venous access, be it peripheral, be it central. Is that okay? So this is how you will approach the patient of variceal bleed with anemia and shock. So initially you will resuscitate this patient, use two large bore IV cannulas, rush fluid resuscitation. Crystalloids are the standards to target a mean arterial pressure of more than 65. Now, once you've done this, usually the bleedings will stop because these are venous bleeds. You have to remember that. These are venous bleeds, veins collapse once they've bled. So there are chances that the bleeding will stop on its own. 90% of the variceal bleeds will stop on their own. It's only 5 to 10% of bleeds that will require intervention. And sometimes, even when the upper GI endoscopy is done, it is difficult to identify the vein which has bled. Sometimes they do tell you that there is this vein which probably has bled but is not bleeding right now. So, initially, you will need to transfuse this patient if their HB is below the critical level of 7, which is the standard worldwide for transfusion cutoff, threshold cutoff, or transfusion threshold. So, if the HB is less than 7, you will like to transfuse this patient with a matched red packed RBCs to a target of more than 9 gram hemoglobin. Platelets, if less than 50,000, you can transfuse, or is there any other option? Anyone? Anyone?
The viscoelastic test.
So viscoelastic is very good as a test, but it will fail if the platelet count is less than 20,000. What will you do? Viscoelastic testing is just a part of the coagulation testing. So once you do the coagulation testing, you feel that the patient requires platelets, but the patient has, let us say, platelet count of 45,000. What will you do? If the platelets are not available, what will you do? Is there any other plan B?
For a variceal bleed, we can put a local compression. Whole blood, we don't give it.
No, no, no. So we, in that situation, give thrombopoietin, which is available in oral formulation as L-Thrombopag. So L-Thrombopag is there in the guidelines that if you want to perform endoscopy in a patient who has thrombocytopenia of cirrhosis patient, and you want to go for an upper GI endoscopy, you don't want to risk the bleeding, then what you need to do is give them L-Thrombopag 50 milligrams once a day. This is a bailout procedure. Why? Because it is a fast acting drug. Once you give it, it is orally given, and it is also recommended in the guidelines to begin if you intend to do a procedure. If you do not intend to do a procedure, then giving L-Thrombopag or even platelet transfusion is not mandatory. It is only for procedures. If you see that the patient has stabilized, the you may not find anything, then the chances are that you may not use. But if the variceal bleed is continuing to happen, hemoglobin continues to deteriorate, then you need to go in with an upper GI endoscopy. You need to ensure that the platelet count is normal. That you do either with transfusing them platelets or giving them L-Thrombopag. That is ELTROMBOPAG. So L-Thrombopag, which is a thrombopoietin or thrombocyte stimulation colony factor, thrombocyte colony megakaryocyte stimulating factor. Along with that, you can give FFP or cryoprecipitate because cirrhosis patients have coagulopathy of vitamin K dependent coagulation factors. Tranexamic acid is not recommended. So, although in every ICU, in every hospital, it is being used, but for the guidelines and for the examination purpose, if there is a question which of the following you will not prefer, then tranexamic acid is what you will not prefer. Is that okay? Why? Because tranexamic acid works with the help of platelets. Is that clear? And the platelets are very low. So how will it help in the improving the coagulopathy. So tranexamic acid is not routinely used for variceal bleeds. All right. So once the patient has been stabilized, resuscitated, you've given the patient blood, okay, you've given platelets also, you've given FFP, what else to be given? As soon as you suspect a patient of variceal bleed and you've resuscitated the patient alongside, use terlipressin as a vasoactive agent. So it will cause splanchnic vasospasm. So terlipressin will reduce the bleeding, plus it will improve the urinary output. How will it improve the urinary output? By causing better blood flow to the kidneys. So terlipressin is not only indicated to stall the bleeding in case of varices, but is also indicated in the management of hepatorenal syndrome. Alternatives to terlipressin are octreotide infusion, very less used. Terlipressin is now the standard of care. Along with always give antibiotic. Why? Because in cirrhosis there is gut edema, and along with gut edema there is bacterial colonization. That is why all the cirrhotic patients are on rifaximin and pre-probiotics. So this patient, if they have bled, it means you have given a ready-made diet for the bacteria to grow on. So you will have to give them antibiotic prophylaxis the moment you realize the patient has a GI bleed. So all the patients of GI bleed must be on ceftriaxone 1 gram IV twice daily to improve the mortality and reducing the chances of gut related septicemia. Okay. So after the patient has been stabilized, you will take up the patient for endoscopic intervention to look for any active bleeding source or any active bleeding varices. So it is diagnostic and therapeutic. Diagnostic, as you will see the varices, and therapeutic, they will either do band ligation or they can inject the vein with a sclerosing agent. So either a band ligation, which is preferred one, or sclerotherapy or glue can be done for gastric varices. Can anybody tell me why gastric varices cannot be banded? Any idea? It will cause gastric gangrene. There are reports of people going for gastric variceal ligation and then leading on to a complication, that is gastric gangrene. So that is why it is not recommended. All right. If the endoscopy fails or you are not able to find the varices, probably they are distally down, below the stomach, then you will have to do balloon tamponade. You will just generally do a balloon tamponade. Sometimes it's not a proper, this varices. It is like multiple capillaries oozing out blood. So balloon tamponade with a Sengstaken Blakemore tube, you can use temporarily only for maximum 24 hours. Why only 24 hours? Any idea?
See, esophageal necrosis.
Perfect. So the same reason why we do not do gastric variceal ligation, the same reason is that if you keep the tamponade on for more than 24 hours, the chances of esophageal necrosis or esophageal gangrene are very high. If uh, that is not there and the center is equipped for a liver transplant or a TIPS procedure, then you can take the patient up for a transjugular intrahepatic portosystemic shunt. The only problem is, what is the complication of TIPS procedure in a variceal bleed?
Hepatic encephalopathy chances are very
Worsening
high.
of. Okay, can you tell me why hepatic encephalopathy happens in case of variceal this procedure?
So because the ammonia directly enters the systemic circulation and
Wonderful. So it does not pass through the liver. It directly goes from the portal vein into the inferior vena cava. So that is literally bypassing the system, and directly the ammonia enters the circulation, and hence there is immediate, within 1 hour the patient goes into encephalopathy. So surgery, rarely it is done, and I have not seen in my career a surgery being performed for variceal bleeds, because the technology and armamentarium is so well now. Of course, these patients will require support for hepatic encephalopathy and hepatorenal syndrome. So, monitor for encephalopathy post the bleed. You Once you put in the scope, you've stopped the bleeding. This blood, which was already there, is now in the colon. You need to flush it out with the help of lactulose. Avoid overtransfusion. Why? These patients can have high chances of hepatopulmonary syndrome in response to excessive transfusion, which is literally synonymous with ARDS. So these patients should be cautiously transfused with guideline based targets only. Be vigilant for hepatorenal syndrome, and if hepatorenal syndrome sets in, give terlipressin, albumin, and midodrine. So this is the standard for care of patient who has HRS. You give terlipressin, albumin, and midodrine. MELD scoring and child pug scoring is generally done. MELD scoring specifically is done for patients who are undergoing or are planning to be done for taken for liver transplant. To assess the GI bleed severity and need for intervention, ROCAL scores are asked randomly in the exam, although Glasgow Blatchford scores are also there. All right. So let's see what mistakes usually candidates do in the exam. So pitfalls are: number one, delaying vasoactive therapy. So as far as the vasoactive therapy is concerned, it uh, vasoactive therapy is starting terlipressin as soon as possible until the endoscopy is done. Another pitfall is not starting antibiotics. It is very, very essential that you start these patients on antibiotics as soon as possible, as soon as the variceal bleed is identified. Giving excess fluids or transfusing to more than 10 grams hemoglobin. You only want 10 grams hemoglobin, that is all. Failing to consider airway protection because these patients may be in encephalopathy already and can aspirate and die. Ignoring potential coagulopathy. So, all these five major pillars of managing a patient of cirrhosis with variceal bleed are to be addressed and taken care of simultaneously. It is not that who comes after. So, it has to be done. All five have to be taken care of at the same time. So this patient who came to us with variceal bleed and hemoglobin of 7.2 and BP of 82 by 48. Now this patient got intubated due to altered mental status and persistent vomiting. Now you started terlipressin and ceftriaxone. Band ligation is done 6 hours later with temporary control. Now, what is the plan? The plan is that this patient is intubated. We know cirrhotic patients are very low on immunity. So they are very high risk for developing VAP. So many times what will happen is in the CBS case or case based scenario, what will happen is they will take your patient from variceal bleed to ventilator associated pneumonia. Okay, because it will it will instigate you to differentiate between ventilator associated pneumonia or what you call hepatopulmonary syndrome. So you will monitor their hemodynamics and urine output very closely. Urine output, why? Because these patients need to be identified for hepatorenal syndrome onset and treated as soon as possible. Even after the ligation has been done, you need to continue terlipressin for 3 to 5 days. And in case you feel that the hemoglobin is persistently falling, sometimes when you just ligated a variceal bleed in the esophagus, the gastric varices might open up because of back pressure. So when the patient is bleeding in the esophagus and you see the focus, the gastric varices are usually not bleeding because the decompression is happening at the esophageal level. It only happens when you ligate the venous bleed in the esophagus that the patient start bleeding in the gastric front. So repeat endoscopy, add a PPI if the gastric varices are or the concurrent ulcer bleeds are suspected, and monitor for infection, AKI and encephalopathy, and try to wean off this patient. Is that clear? How the train of thought should work with the patient of encephalopathy? Is that clear?
So the portion you told that only when the viruses are ligated, they I that portion I lost.
So basically, once you ligate the venous these varices in the esophagus, what will happen? The back pressure will be referred to the stomach because it has come from the portal vein, right? So
Yes, yes.
portal vein first reaches the gastric veins, then it reaches the esophageal veins. So if you have ligated the esophageal veins, what will happen is there will be pressure in the gastric veins, back pressure.
Yes, yes,
So that back pressure will lead to opening up of gastric varices now. So initially the patient presented with esophageal varices, but will later on develop gastric varices. So if the patient continues to bleed and you are sure that the esophageal varices were ligated, then the only possibility is a gastric varix. How will you identify it? Again, repeating a endoscopy. Okay,
thank you, sir.
that usually happens on day 3, 72 hours later. So again, the patient, so how the question will be framed: that the patient was taken up, endoscopy was done, venal ligation was done, and now the patient is stable. Third day in the ward, the nurse calls you that the patient has again had an hematemesis.
Okay.
So what is the suspicion now? So one suspicion will be what do you call, gastric varices. The other suspicion would be another esophageal varix. Okay, is the page visible? Hello.
Yes, sir.
So the question is, which of the following is most appropriate immediate step in a patient with suspected variceal upper GI bleed? Urgent endoscopy, IV proton pump inhibitor, IV terlipressin, inserting a Sengstaken Blakemore tube, or platelet transfusion.
IV totally present, sir.
So starting vasoactive drugs immediately before endoscopy is the standard of care. Which of the following improves survival in cirrhotic patients with variceal upper GI bleed? IV pantoprazole, tranexamic acid, early tips, ceftriaxone, or immediate CT angiography?
Cef- Ceftriaxone prophylaxis.
Yes, so antibiotic prophylaxis is important. What are the 3 criteria for tips in variceal bleed? So these are refractory or recurrent variceal bleed despite endoscopic or medical therapy, patients with Child-Pugh criteria B or C without any contraindications, and a reasonable hepatic reserve and no active sepsis. These are the major criteria for selecting the patient for tips. This is a important short answer question from which many questions can be framed. So these are the 3 major reasons of selection criteria for patients who can be taken up for tips following variceal bleed. Is that okay? So key takeaways are that you need to start resuscitation early, start vasoactive therapy, take an endoscopic control. These are the cornerstones of management. Antibiotics reduce infection and mortality directly. Transfusion strategy should be conservative, aiming for a hemoglobin less than 10 grams and not letting the HB drop to less than 7 grams. Okay, then balloon tamponade and tips, they are reserved for resistant cases. Always monitor for post bleed complications in cirrhotic patients. So what are the post bleed complications? Number 1, rebleed. Number 2, encephalopathy. Number 2, patorenal syndrome. Number 4, septicemia. Okay, now we will cover the toxidromes, very important topics again for EDIC. What is a toxidrome? Toxidrome is basically a cluster of manifestations that happen with respect to the kind of toxin taken by the patient. So it is basically toxicology and poisons. So constellation of signs and symptoms that point towards a specific class of poison. Recognizing the toxidromes is important, and because if you realize that, for example, a patient has taken some unknown poison, the pinpoint pupils are there, the patient has bradycardia, the patient is drooling saliva, the patient is having polyuria, diarrhea, then we know that this patient most likely has a this pesticide OPC. Okay. For now, let us take a clinical vignette. A 28-year-old female is brought to the ICU after being found unconscious with a pinpoint pupils and shallow respirations. No clear history is available. Heart rate is 52 beats per minute. Respiratory rate is 6. Blood pressure is 92 by 56. Saturation oxygen is 84 on room air and GCS is 7. Can anybody pinpoint the toxidrome? Pinpoint pupils, shallow breathing, bradycardia, shallow
Opioid.
respiration, low BP.
Opioid.
So one is opioid. How will opioid cause a bradycardia? So by deep sedation, the bradycardia can happen. So general approach will be ABCD framework. Airway needs to be secured. If the patient is GCS less than 8, you will like to intubate the patient. Breathing has to be supported when the respiratory rate is less than 10. Initially bag valve mask ventilation. And if the patient doesn't become conscious, requires longer than 10 minutes, then you will need to intubate the patient. As far as circulation is concerned, hypotension, bradycardia, arrhythmia. These are the major three features that you need to look for in a patient of toxidrome. Looking for pupils, neuromuscular tone, and seizures is an important cardinal sign. Neurological assessment is important. Intubation has one important criteria if the patient is GCS less than 8. So that is the neurological criteria. You need to fulfill them and then intubate the patient and control their ventilation. Look for any needle marks, any skin findings, any specific odors, like in case of aluminium phosphide or in case of organophosphorus compounds. You can actually have a odor which is particular to the toxin. Remember, decontamination and antidotes are secondary to stabilization. So initially, you will just stabilize the patient, maybe by intubation, giving them fluids, resuscitating them, uh, and then going for decontamination and antidotes. So, what are the common toxidromes with diagnostic clues? I'm giving all of them. So, toxidrome, CNS, pupil size, vitals, key features, examples, and agents. We should be looking with these particular headings. So in opioid, the CNS is depressed, pupils are pinpoint, vitals are bradycardia and hypotension, hypoventilation, low respiratory rate, and key features are track marks for heroin injections, morphine, and fentanyl. These are the major agents that cause these toxidromes. As far as anticholinergics are concerned, the patient will be agitated, pupils will be dilated, there will be tachycardia, there will be dry skin, there will be urinary retention, delirium. So TCAs, antihistamines, and in Indian context, datura poisoning is important. Cholinergic, for example, oral these organophosphorus compounds. Patient will be confused, may have seizures. These patients also have pinpointed pupils with brady or tachy. There will be bronchoria, lot of fluid being released into the tracheobronchial tree, and you can have a sludge or when you aspirate it out. So organophosphates and physostigmine are the drugs which can cause the same thing. Sympathomimetics like cocaine and amphetamine can have agitated patient who is throwing seizures. Pupils will be dilated. There will be tachycardia. On ECG, you may have an ST elevation which is present in the global. Can have angina also along with. So hypertension, hyperthermia, sweaty palms, and tremors. So sympathomimetic. Sedative hypnotics like midazolam, barbiturates can cause a depressed patient with normal or slightly constricted pupils with bradycardia, hypotension, and dizzy and ataxic patient with slurred speech. Serotonin syndrome sometimes comes in the exams. Agitated patient with the clonus, dilated pupils, tachycardia, high grade fever, myoclonus, hyperreflexia. So SSRIs, MAO inhibitors, and MDMA, all of them can cause such a syndrome. The overlap is with neuroleptic malignant syndrome, which also presents similarly with rigidity, a silent mute patient with normal sized pupils, patient having tachycardia, Malignant hyperthermia, temperatures of 107, 105, lead pipe rigidity, and usually haloperidol or metoclopramide also can lead to such a condition. And sometimes the shorter version of NMS, that is oculogyric uh, response or oculogyric syndrome, may be present in the patient. So specific antidotes are, in case of opioids, it is naloxone. In case of benzodiazepines, it is flumazenil. Avoid in patients of chronic use. Why giving flumazenil in a patient who is taking chronically benzodiazepines can throw seizures in this patient. Organophosphates, atropine and pralidoxime is the standard. For paracetamol poisoning, N-acetylcysteine is the standard. For methanol ethylene glycol, either using fomepizole, which is a reductase inhibitor, alcohol dehydrogenase inhibitor, or ethanol itself can be given to tide over the situation. As far as cyanide is concerned, hydroxycobalamin or sodium thiosulfate can be used. And in iron overdose, desferoxamine, and in TCAs, alkaline diuresis, using lot of soda bicarbonate is preferred technique. Also, in cases of TCA, because they are acids, giving soda bicarb alkalinizes the pH, try to reverse the acidotic part, and hence it does the reversal of the poisoning. ECG is very important. You should look for the ECG clues in the exam. Look for QRS duration. If it is more than 100, look for TCA poisoning. QTC prolongation happens in SSRIs, antipsychotics, or even arsenic poisoning. Bradycardia happens in beta blocker poisoning, calcium channel blocker poisoning, digoxin poisoning, organophosphorus compounds poisoning, and opioids also can lead to bradycardia. Of course, all the sympathomimetics like MDMA, TCA, cocaine, all of them can also lead to arrhythmias, ventricular arrhythmias. So, case correlation, if a patient with overdose has a wide QRS and hypotension, think of TCA, give sodium bicarbonate. This is just an example. So, decontamination strategy, there are major 5 decontamination strategies that are usually asked, that you will need to remember by your heart. One is, where is activated charcoal used? So within 1 hour of ingestion, unless corrosive or hydrocarbon. Gastric lavage, rarely, only if life-threatening ingestion less than 1 hour ago and the patient is fully conscious. Otherwise, while gastric lavage, patients can aspirate and die. Whole bowel irrigation is specifically performed in cases of iron, lithium, and drug packets. Urinary alkalinization is done in case of salicylate and phenobarbital and in TCA. Hemodialysis is very important because this question has been asked many times, that which of the toxidromes are amenable to hemodialysis. Then lithium, methanol, valproate, and theophylline are the drugs which can be removed by hemodialysis. Monitoring these patients of toxidromes in ICU requires serial ABGs and lactate levels. Always monitor renal and liver function, because sometimes nowadays this paraquat poisoning is coming. So you will need to dialyze these patients immediately as soon as possible, even when the creats are normal. Why? To remove the drug from the system. Continuous cardiac monitoring, because of possibility of arrhythmia being caused by these drugs, is important. And also, when sometimes when you give treatment, then arrhythmias can happen. For example, in flumazenil and naloxone, when both of them are given, there are high chances of patient developing hypertension and arrhythmias. Seizure precautions, specifically if the patient has taken tramadol, if the patient has taken TCA, if the patient has taken opioids, has been on chronically on opioids, and patients who have taken organophosphorus compounds. And in case of respiratory depression, go for ventilatory support. So in this case, we suspect opioid toxicity. So patient was given zero point 0.4 milligram IV naloxone. The patient improves over 2 to 3 minutes. Respiratory rate becomes normal. She later confesses to taking heroin. Can anybody tell me what is the indication for giving flumazenil in benzo poisoning? What is one indication of giving flumazenil in benzodiazepine poisoning?
Cardiac arrest or single
Uh,
indication.
Basically, it is respiratory depression. If the respiratory rate is less than 10 or the patient is having gasping breathing, then you will immediately give a single shot of flumazenil. So the criteria to give flumazenil in benzodiazepine poisoning is always respiratory depression or impending cardiac arrest. Is that clear? So look for these things in the question. So what will be the ICU plan? Monitor for recurrent respiratory depression. Why? Because naloxone's half-life is shorter than the opioid. So you will need to give it again probably. Continue naloxone infusion if the bolus of the drug taken is very heavy and the patient is going into respiratory depression again and again. Screen for any co-ingestants like alcohol, benzodiazepines, and of course psychic evaluation before the patient is discharged. What are the pitfalls? Usually, number one, not intubating early. So just thinking that this patient will recover after the toxidrome has been identified and antidote has been given. Remember, antidote and decontamination take secondary stage. Primary stage is resuscitation. In resuscitation, intubating the patient whose GCS is less than 8 is paramount. Misdiagnosing anticholinergic versus sympathomimetic. Check skin moisture. So in case of anticholinergic poisoning, the skin moisture will be not there and the patient will be dry. Giving flumazenil in chronic benzodiazepine user will throw the patient into seizures. So do not do that. Relying too heavily on toxicology screens, develop a clinical diagnosis first, aiming on the toxidrome knowledge. Overlooking serotonin syndrome in patients who are on antidepressants with new seizures and hyperthermia. Always, usually, whenever I talk to candidates, their mind is fixed on malignant neuroleptic syndrome. When serotonin syndrome is also a condition that presents with the same type. So you need to know that. So let's practice few questions. A patient with overdose has dilated pupils, dry skin, and urinary retention. Which of the agent is most likely involved?
Anticholinergic.
Perfect. So anticholinergic. The next best step, a patient with massive TCA overdose has QRS widening with hypotension. What will you do immediately?
Bicarbonate. Bic-
Perfect. So you will give sodium bicarbonate immediately. All right. All are the features of serotonin syndrome except clonus, lead pipe rigidity, hyperthermia, diaphoresis, agitation. So lead pipe rigidity, which is a feature of haloperidol or neuroleptic malignant syndrome toxicity. Okay, key takeaways are you need to recognize the patterns, not the poisons. So toxidromes, you need to know they guide the empirical therapy, stabilize the patient first, control their airway breathing and circulation, use their antidotes judicially, and be cautious with flumazenil and lavage. Many times they are harmful. Expect complications like seizures, arrhythmias, and organ failures in case of these patients. So this is basically the topics that were assigned to me. Although I have another topic also for you guys, but what I'll do is I'll send it to Sana so that she can share with you. This is a combined topic that is acute renal shutdown and CRRT. So it is a very lengthy. It requires a full class in its own, and it is very important also because nowadays CRRT is in the vogue. So what I'll do is I'll just touch the main points. Okay, Sana, we just have few minutes left. So I'll just touch the main points and I'll send it to Sana so that she can share the class with you guys. Is that okay?
Please.
So basically, acute kidney injury in the ICU. It is a very important topic. So we all know that it is a pre-renal, renal, and post-renal. I want to ask all of you a very important question. A patient in whom a patient is in ICU in whom you have ruled out all the possible causes of acute kidney injury, and the patient is having oliguria and rising creatinines or worsening AKI, what is the most common reason.
Drug induced.
Say again.
Drug induced.
Okay. Anybody else with a different answer?
Pre-renal.
Anybody else with a different answer? Okay, I'll tell. So in case of, I told you, you've ruled out all the other causes. You've ruled out drug causes. You ruled out all the causes. So the only reason for a patient to have worsening renal function who is admitted in the ICU for any disease, any condition, is septicemia unless proved otherwise. The total leukocyte count may be normal. Septicemia is very deceptive. It usually presents with acute kidney injury. Many times in ICU, you see that the patient deteriorates with decreasing urine output and you cannot find an obvious reason. The reason is septicemia and endotoxemia, could be fungal. So you have to treat it very aggressively, or these patients, they go on to develop worsening renal function. This is the basically a mandate. Now it is, I mean, if you read the best journals, you will come to know that it is mentioned as a, what you say, it is one of the dictums of medicine, critical care medicine, that if you do not find any reason for acute renal shutdown in ICU, look for sepsis somewhere. Okay. And of course, look for obstruction in the urinary catheter. All right. So these are the basic definitions and etiologies. So all kind of AKIs, ischemic, nephrotoxic, intrinsic renal AKI. So all of them are included in this lecture. So diagnostic evaluation, you all know all of that part. So the important part is management. So you must rule out the pre-renal part and optimize the perfusion, avoid colloids. It is very important in all the EDIC exams. Many times students say colloids, do not use colloids. KDIGO specifically recommends crystalloids over and above colloids for volume expansion in AKI. Recent evidence favors crystalloid, balanced crystalloids like plasmalite, cabelite, and all these things. Aim for a mean arterial pressure more than 65. So avoid fluid overload. Many times what happens is, considering a patient of renal shutdown, we always first think of pre-renal and we keep loading the patient with fluids. So avoid fluid overload in these patients. And after initial resuscitation, target either neutral or negative balance if possible. That is the dictum. If AKI progresses despite diuretics and fluids, ultrafiltration via RRT early has to be subjected to. Give good vasoactive support. Mean arterial pressure has to be maintained above 65. Using vasopressin or angiotensin 2 may be a thing of future, but it will soon come in the guidelines. Avoid all kind of nephrotoxins. Monitor and correct the electrolyte imbalances. If potassium is 6.5, forget about everything, go for hemodialysis. If acidosis is there, go for hemodialysis. It is basically AEIOU. A is acidosis, E is electrolyte imbalance, I is infection, O is fluid overload, and U is uremic symptoms like uremic encephalopathy. So these are the AEIOU. And of course, nowadays AEIOU and D is involved, that is decline. Persistent progressive AKI without complication is a subjective indication for RRT. So nowadays, in all intensive care exams, they are basically focusing on continuous renal replacement in ICU. So whenever patient is hemodynamically unstable, we prefer CRRT over and above all types of intermittent hemodialysis because of gentler fluid removal, and CRRT will run 24 hours a day, avoiding large volume swings, leading to minimal blood pressure changes. It is of two types, CVVH, which is basically continuous veno-venous hemofiltration, where we use convective clearance. So blood is pumped through a hemofilter under pressure, plasma water is removed along with the solutes. Replacement fluid is infused So it is infused from outside to match or exceed ultrafiltrate volume to achieve desired fluid removal. Effectively removes middle molecule cytokines better than diffusion. So nowadays, CVVH is considered better than the regular hemodialysis, which is veno-venous hemodialysis, which is also using diffusive clearance. So nowadays it is not preferred as much, but it for potassium it is very effective CVVHD. Otherwise, it is CVVH. And then comes the CRRT's main continuous veno-venous hemodiafiltration, which has both dialysate and higher ultrafiltration replacement rates, maximizing solute clearance. This is the most expensive but is most effective method of CRRT also. So, as far as the CRRT prescription and parameters are concerned for critical care physicians, using a large bore 11 to 13 dual lumen CV line is important. Blood flow rates can be 100 to 200 ml per minute. Ensure a good blood flow. Effluent rate has to be 20 to 25 ml per kg per hour. It has been asked in the exam, so you need to remember it. Effluent is equal to dialysate flow plus replacement fluid plus ultrafiltration. This equation needs to be remembered by heart if you want to practice in Europe, because in Europe the intensivists they take care of the CRRT effectively. So you need to know how much effluent you are going to take out. Or because of the downtime, aim for a slightly higher to deliver more like 20 to 25. So anticoagulation is very important. So regional citrate anticoagulation, that is RCA, is preferred these days, usually 4% solution. The only problem is patients who have renal failure with liver dysfunction. So watch for citrate accumulation in liver failure. It can cause an ion gap metabolic acidosis, rising total calcium with falling ionized calcium. It is very, very, very important. And citrate excess is not a bothersome to us if the liver is healthy, because liver will convert the citrate into bicarbonate. So I have few examples of questions, and of course heparin can be used. So few examples are there. For example, septic shock with oliguria. For example, a 65-year-old man in septic shock becomes oliguric. The creat has doubled in 2 days. Initially, ensure a MAP of more than 65. It is the first and foremost. Second is giving IV fluids, which is a balanced crystallite solution, stopping any nephrotoxins, checking urinalysis, FENA, and response to fluids. And if urine output and MAP do not improve, oliguria persists, starting CRRT since this patient is in shock. Again, another question is about diuretic infusion. A patient on IV furosemide for pulmonary edema develops AKI. Now, the FENA is 2.5%, suggesting intrinsic AKI. However, a fractional excretion of urea is 25%. So, low urea suggests the AKI is actually pre-renal. So, diuretic is the reason behind the pre-renal. So, you will give fluids to the patient. Interpreting FENA in context of diuretics without using Fe urea leads to misclassification of AKI. Is that clear? This is very important. This is coming big waves. So we just keep remembering about FENA, but you have to read about the Fe urea also. Contrast induced AKI, you please read it from the notes. I will give it to Sana. So pitfalls in AKI management as far as EDIC exam is concerned is number one, understanding AKI. Even small creatinine rise, don't ignore it. If they have mentioned that the patient had a creat of 1.8 and now it is 2.0, it is an AKI. Specifically, when creat rises from 1.3 to 1.6, don't take it with a pinch of salt. It is impending AKI. Missing postrenal, always rule out obstruction, always. Inadequate fluid management, both hypo and hypervolemia can worsen the AKI, target euvolemia. Nephrotoxin oversight, always look for the list of drugs being given and stop all the nephrotoxins. Delaying RRT, waiting too long in hyperkalemia acidosis can cause arrhythmias, fluid overload, encephalopathy, hemodynamic collapse. So initiate renal replacement therapy when the patient can still tolerate. Inappropriate RR dose, so prescribe 20 to 25 ml per kg per hour, but ensure delivered dose is adequate. Neglecting citrate effects. Whenever the patient is being given citrate, look for ionized calcium and acid base to avoid citrate toxicity. So this is all about it, and then there will be some MCQs. You please take care of these MCQs by yourself. I will be sending them to you. Okay, doctors. So I will take your leave now. Okay, Sana. Uh, what I'll do is I'll send these notes to you so that you can share with the three doctors. Okay.